Hi, everyone. Welcome to Report from ASCO, What's Happening in Metastatic Breast Cancer Research and Treatment with Dr. Don Dizon. My name is Christine Benjamin, and I'm the Breast Cancer Program Director at SHARE. Today's webinar is in collaboration with the Metastatic Breast Cancer Network. We're thrilled to have Shirley Mertz, the president of MBCN, with us today. Dr. Dizon is board certified in medical oncology and is the clinical co-director of gynecological oncology at the Massachusetts General Hospital Cancer Center, where he is also the founder and director of the Oncology Sexual Health Program at MGH Cancer Center. He's an associate professor of obstetrics gynecology and associate professor of medicine at the Warren Albert Medical School of Brown University and is pending a similar appointment at Harvard Medical School. He serves on multiple national committees and is currently the co-chair of the National Cancer Institute's Gynecological Cancer Steering Committee Cervical Cancer Task Force. Dr. Dizon, welcome and thank you so much. It's all yours.
Hi. Thanks very much. It's always an honor to work with Cher as well as the great folks at MBCN. They have asked me to summarize some of the research that was presented at the annual meeting of the American Society of Clinical Oncology. And this presentation will emphasize the work that set out to me on treatments in metastatic breast cancer. So in terms of a summary of what we learned in ASCO, there was one that I did consider as a breakthrough, and it was for women with hormone receptor positive metastatic breast cancer, and the results were of the PALOMA 3 trial showing a benefit to fulvestrant when it is combined with the biologic CDK4/6 inhibitor palbociclib, which has been FDA approved for use in metastatic breast cancer already. We did have promising treatments for triple-negative metastatic breast cancer as well. And one study that I'll talk about used the poly-ADP ribose phosphorylase inhibitor veliparib, and the other an androgen receptor inhibitor called enzalutamide. And then we did have some clarifications in our approaches to women with metastatic breast cancer that is HER2 positive, and those results were from the MARIANNE study. Another study looking at bevacizumab in hormone receptor positive metastatic breast cancer. And then for women with bone metastases, we had some clarifications on how we use the bone strengthening bisphosphonate zoledronic acid, as well as for women who are diagnosed with brain metastases, the role of whole brain radiotherapy was discussed. I'll end with some future directions on both targeted treatments as well as immunotherapy, which draw not only from the ASCO annual meeting, but from the American Association for Cancer Research meeting as well. To get started, what I thought I'd do for this audience was try to make sense of the studies in the probably simplest way possible, and it's how we look at these data when we try to essentially summarize it for ourselves in terms of what they mean. And I'm going to use what is often called the PICO criteria. And PICO stands for P, patients, who was exactly enrolled in this trial. I is the intervention that was studied, C, if relevant, what comparator was used, and then O, which is the outcomes, which usually consists of not only the comments on survival or other benefits like response rate, but should really help clarify what are the drawbacks of treatment, what are the risks, as well as the side effects of any therapy. Not every study, as I'll present, had a comparator arm. Some of these trials were single-agent studies, and as such, would not likely or would be prematurely influencing availability of drug or even challenging standards of care, but rather point to a future direction and further trials on whether or not they were indicated. So the first trial is PALOMA 3. It was presented by Nick Turner, and it was a late-breaking abstract presented in the oral session. The P here are women with progressive disease on prior endocrine therapy for a hormone receptor positive breast cancer. In this trial, both pre- and postmenopausal women were enrolled. The intervention was palbociclib, which was given orally 3 weeks in a row, followed by a week off, with fulvestrant, which is an intramuscular injection given monthly. The comparator here was fulvestrant with a placebo preparation. And in terms of who these women were specifically, this study was notable because 1 in 5 women were pre or perimenopausal. So these women had received an endocrine treatment for metastatic disease, and 1 in 5 had not achieved menopause. 80% of these women had prior hormonal therapy, but only a third of these women had prior chemotherapy. And looking at the population more specifically, over a third had 2 or more lines of prior treatment, and that means that they likely had treatment in the first-line setting or adjuvant context when they were first diagnosed with breast cancer, and then treatment in the metastatic setting. In terms of outcomes, we'll start with the toxicities. So comparing fulvestrant with placebo, the incorporation of palbociclib with fulvestrant was associated with higher rates of neutropenia, and this could be very serious, meaning that either landed them in the hospital or else required intervention like antibiotics. But beyond that, there is no significant difference if you look at non-hematologic toxicities, and in fact, they were rare in both arms. So in both the placebo fulvestrant as well as placebo or palbociclib fulvestrant arms, there were rarely experienced non-hematologic toxicity. So that is things like arthralgias, alopecia, diarrhea. In terms of survival endpoints, what you're seeing here is the progression-free survival. And what Dr. Turner presented was the subgroup analysis. So each of these bolded criteria on your left are the subgroups in terms of age and race and menopausal status, whether or not they had visceral or non-visceral metastatic disease, so involvement of the liver and lungs, for example, whether or not prior hormonal therapy was administered, whether or not they were progesterone receptor positive or negative, and how long they were disease-free, whether or not they had prior chemotherapy, and then the lines of treatment. And what you're seeing very strikingly is that all of these bars under the hazard ratio and 95% confidence interval strongly favor palbociclib with fulvestrant in all except for maybe a few cases. So making the argument that this combination is a highly effective treatment for most women with hormone receptor positive metastatic breast cancer. So compared to control arm also, the combination with palbociclib increased the overall response rates and significantly increased what is termed the clinical benefit rate, which is the complete and partial response rates as well as the calculation of prolonged stable disease. What we did not get presented at this time was whether or not overall survival was different. The sole fact being that we need to follow these women for far longer before we can see what the impact of this treatment was in terms of the risk of death or dying of metastatic breast cancer. So the bottom line here is for women who progressed on prior endocrine therapy for a hormone receptor positive breast cancer, palbociclib and fulvestrant is a very good standard treatment option and now represents another one that is available for this population. Well, I think the strength of the study is that the progression-free survival advantage was very strong, despite the fact that the overall response rates were very small, and we saw very little in the way of non-hematologic toxicity differences between fulvestrant alone. As such, I think this is a good option for women who particularly are not looking at wanting to use chemotherapy, or maybe the decision is that their disease does not mandate the use of chemotherapy, this is a good choice for women who are looking at a second-line hormonal treatment, and it will effectively stave off the use of chemotherapy until a much later time. Moving on, we'll talk about the MARIANNE study, and this is abstract 507 presented by Paul Ellis. This was a trial of over 1,000 patients with HER2-positive metastatic breast cancer. And unlike Nick Turner's study in PALOMA, these were women who were receiving first-line treatment of metastatic HER2-positive breast cancer. So they were previously untreated. Although there was 1,095 patients here, 800 were status post 2 years of therapy, and these are the people who are essentially studied in this presentation. The intervention looked at the drug TDM1 or trastuzumab, which is an antibody drug conjugate with pertuzumab as the first arm, versus TDM1 alone or with placebo in the second arm. So there were 2 interventions, and the comparison here was standard therapy, trastuzumab with a taxane, and that could have been docetaxel or paclitaxel. The primary outcome here was progression-free survival, and what you're seeing on this curve is no differences among the arms in terms of progression-free survival. I'll point you towards the third row here, which is the stratified hazard ratio, which gives you both intervention arms, TDM1 by itself or TDM1 with pertuzumab, comparing to trastuzumab with a taxane, and you're seeing the hazard ratios of 0.91 and 0.87, and that the numbers in parentheses are the confidence intervals, both of which cross 1, which means that these differences could be attributable to chance. Other outcomes that we looked at was there was no differences among the arms in terms of response rates. There was no significant differences in the duration of response, although the numbers appear fairly striking. The toxicity, however, appeared to favor the use of TDM1 treatment rather than trastuzumab and taxanes. There were lower rates of alopecia, serious or febrile neutropenia, as well as diarrhea. This correlated with an improvement in declines in quality of life. So with TDM1 therapy, there was a near doubling in time where people actually felt better before the symptoms started to impact the way they were living or the quality of life. So the bottom line here, though, is that for patients with HER2-positive metastatic breast cancer who are looking at treatment to improve progression-free or even overall survival, there's no additional survival advantage to the use of TDM1, either alone or in combination with pertuzumab. Putting this in a bigger context, we do know that TDM1 as a second-line therapy after taxanes, or even a later line therapy after taxanes, appears to improve outcomes compared to continuation of trastuzumab. So the preferential place to use these agents may be after trastuzumab treatment and not as a replacement of trastuzumab itself. Moving forward, we can go to CALGB 40503. This was presented by Maura Dickler, and this was in a different population of women with locally advanced or metastatic breast cancer that was, again, hormone receptor positive. It was a smaller study at over 340 patients. It did allow for women who had received adjuvant endocrine therapy, but did not allow for treatment with endocrine therapy in the context of metastatic breast cancer. Here, the intervention was an aromatase inhibitor, letrozole or Femara, with bevacizumab, and the comparator here was letrozole alone. And in terms of outcomes, again, looking at progression-free survival, we're seeing that bevacizumab, in addition to letrozole, was associated with a gain of at least of approximately 4 months in progression-free survival, and according to the stratified hazard ratio, that did meet statistical significance because, again, the 95% confidence interval was to the left of 1.0. So this was a significant result. However, as we've learned with most studies of bevacizumab for breast cancer, this did not translate into a gain in overall survival. The gain here was about 3 months on median. However, the confidence interval here did span 1. So this outcome could have been due to chance. So bevacizumab alone, or bevacizumab with letrozole, improvement progression-free, but not overall survival. The combination also improved significantly overall response rates as well as that clinical benefit rate, but it came at a cost of higher adverse events, including serious non-hematologic toxicity. No new signals were encountered, so we're looking at bevacizumab well-established toxicities, including hypertension, proteinuria, as well as joint pain. So the bottom line here from this study is that bevacizumab improved some outcomes for women with a hormone receptor positive metastatic or locally advanced breast cancer, and it does it when combined with letrozole. But as again, with most studies of bevacizumab in breast cancer, it did not change overall survival, and it came at a cost of potentially serious toxicities. So moving forward to some of the promising trials that were presented, Tiffany Traino from Memorial Sloan Kettering presented these data on enzalutamide, which is an androgen receptor inhibitor that has approval in prostate cancer. What was interesting about this study is that she looked at it in 100 women with an advanced triple-negative breast cancer, and she wanted to see if some of these patients who have ER and PR negative breast cancer may still express the androgen receptor. The intervention here was an oral treatment of enzalutamide daily. There was no comparator in this trial. The outcome was to see what was the clinical benefit. So that's complete response, partial response, as well as at least stable disease for at least 4 months. What she saw was that about 30% of patients, or 1 in 3, experienced a serious toxicity, although of those toxicities, only about 10% were deemed to be related. The major toxicities that were seen were fatigue and dyspnea. And what was interesting even further, though, is that the clinical benefit rate at 4 months was 35%. And at 6 months, it was 29%, and the overall response rate was 8%. 25% of those patients had a clinical benefit, had an androgen receptor expression above 10%. And in terms of progression-free survival in both the evaluable as well as in what she termed the intent to treat population, and if you'll look, the evaluable patients here stayed on study, and it was 75 patients. The progression-free survival was almost 4 months. In the intent to treat analysis, which had far more patients, she did a stratification by androgen receptor expression. And you're seeing here that about 88 patients had AR expression of 10% or better. And there was a clear stratification of progression-free survival advantage, almost doubling if you were expressing androgen receptors. There was a separate study that was presented but was associated with this trial that looked at a genomic signature for androgen receptor expression, and it was termed the PREDICT AR signature. And if you had that signature, again, there was a clear benefit in progression-free survival, and even among those patients who were less heavily treated, so 0 to 1 prior therapies, the benefit was really quite striking. In terms of overall survival, I thought this is also very important because it does generate the hypothesis as to can we treat triple-negative breast cancer with more precision using enzalutamide by using this androgen receptor profile? And as you're seeing here, with enzalutamide and that androgen receptor profile, there was an overall survival advantage. In fact, of patients on this trial who had the signature present, median overall survival had not been reached. But if you did not have that signature, median overall survival was 32 weeks. So the bottom line here is for women with triple-negative breast cancer, we have potentially exciting results and a potential biomarker to look at an enriched population now of women with triple-negative disease that express an androgen receptor signature, and pointing to the potential that these patients would benefit greatly from the use of enzalutamide. This will warrant further investigation, but I think it is among the more promising treatments that I've seen for triple-negative breast cancer. Speaking on the theme of triple-negative disease, there was a small trial of PARP inhibitors in this population presented by Dr. Pahuja. It was abstract 1015. The population in this study were all patients with advanced solid tumors, but of those patients enrolled, 22 patients had a triple-negative breast cancer. The intervention was the PARP inhibitor veliparib with carboplatin and paclitaxel administered on a weekly basis. There was no comparator. This was a dose-finding study, so it was the phase 1 trial, and what they were able to establish was a randomized phase 2 dose, the recommended phase 2 dose, RP2D, of veliparib at 150 milligrams twice a day with weekly carbo as well as weekly paclitaxel. There are reported results within these 22 women, again a very small number. Median progression-free survival among those patients with a mutation in BRCA was 10 months. There was no difference in that in median among those patients with a negative BRCA mutation. But if you had an unknown BRCA mutation, it was 5.5. Unclear what this means, but again, fairly impressive findings, particularly if you look at the overall response rate in triple-negative breast cancer was 52%. Again, really too small to be conclusive at all, but does show a point of principle that perhaps using a platinum in triple-negative breast cancer alongside a PARP inhibitor may be an effective strategy. Moving on, we'll look at a couple of supportive care abstracts. This was CALGB 7064 presented by Dr. Himmelstein. And this is a study in almost 2,000 patients with bone metastases. It was open to patients with breast cancer, prostate cancer, as well as multiple myeloma, 800 of whom had received 2 years of therapy. The intervention here was simply to extend the time between infusions. So in the intervention arm, zoledronic acid was delivered every 3 months. In the comparator arm, zoledronic acid was given monthly. The outcome here was the skeletal-related event rate. So those are things like fracture or worsening pain. And there was no difference between every 3 months versus monthly treatments. It was 29% in both. There's no difference specifically in pain scores or worsening in performance status. There was rare events of osteonecrosis of the jaw. There were rare events of kidney problems. However, it was a comment during the discussion of this trial that we would likely need more follow-up before we would see any differences in toxicity. So the bottom line here is that for patients who are living with bone mets, we do not need to treat them as frequently as we thought we needed to. Treatment every 12 weeks appears to be as safe as more frequent therapy. NCCTG's study, N0574, looked at patients with brain metastases. And it was a smaller study of 200 patients who had less than 3 brain metastases, and each had to be small or less than 3 centimeters. Everybody got stereotactic radiosurgery, which is usually the treatment of choice for brain metastases, but there's always been this concern that unless we treat the whole brain, that outcomes might be worse. So in the intervention arm, patients got whole brain radiation as well as stereotactic radiosurgery, and the comparator here was stereotactic radiosurgery by itself. With a median follow-up of 7 months, they were able to demonstrate that the addition of whole brain radiation was associated with a significantly more frequent cognitive decline, worse quality of life, and greater cognitive deterioration. However, the benefit of whole brain radiation was that there was a benefit in terms of disease progression intracranially, and it was a near 4-fold improvement at 3 months and a 3-fold improvement at 6 months. So there was a gain in having brain metastases not progress if we use whole brain radiation with stereotactic radiosurgery. However, also importantly, there was no difference at all in overall survival. So the bottom line here, at least my takeaway, is that for patients with 1 to 3 brain metastases, stereotactic radiosurgery is as effective as stereotactic radiosurgery with whole brain radiation. It is also better tolerated with less cognitive decline, and given that there is no overall survival advantage, it probably should be the standard for most patients, although we would still argue that decisions about whole brain radiation need to be individualized. So to conclude, here are some promising leads that were also presented. Palbociclib is the first CDK4/6 inhibitor that was presented, but there are others that are on the horizon. And Sarah Taleni from Dana-Farber presented one using abemaciclib that also seemed promising. And then they were also looking at these antibody drug conjugates, and one that I looked at was involving IMMU-312, which is a monoclonal antibody to the trophoblast cell surface antigen, or anti-TROP2, and it's conjugated to SN38, which is an active metabolite of a fairly commonly used chemotherapy in colon cancer called irinotecan. Beyond those, there was some really interesting data presented at the AACR on immunotherapy, and specifically looking at an anti-PD-L1 antibody called MPD-L3280A, which looked like it was active in women with triple-negative breast cancer. And this was presented by Leisha Emmons of Hopkins at AACR 2015. Among those patients, the overall response rate was 90%, and a very small number with a PFS, or progression-free survival, at 6 months, among, again, patients with triple-negative breast cancer of about 27%. Again, even in this study, very small numbers, lack of a comparator, doesn't mean this is conclusive and we should all be treating triple-negative breast cancer with an anti-PD-L1 antibody. But again, proof of principle might be here, and we need to take these data further. This is just a slide looking at one of the slides presented by Dr. Bardia on this drug IMMU-312, which in the women with triple-negative breast cancer showed a 31% response rate. And what he showed here was a really striking example of metastatic disease involving the breast and the chest wall in this one patient. And what is circled in panel A is some axillary adenopathy, which is quite significant, and in panel C you see it shrink down quite significantly as well. And in panel B you're seeing actual clearance of some axillary adenopathy as well as some mediastinal adenopathy. And if you look at D, the area actually looks quite clean. And she has continued treatment, as of May of 2015 with a striking 60% shrinkage in her tumors. Again, these are anecdotes. Doesn't prove that this drug is going to be any better than standard of care, but again, really promising results for a woman with metastatic disease that is also triple negative. So I'm hoping I can convince you that we are making progress. And what struck me about the ASCO annual meeting is that this progress was no longer being seen in studies looking at all breast cancers as one disease. We are looking at now studies being done in specifically defined populations, whether it be HER2 positive or hormone receptor positive, as well as in triple negative breast cancer. And I think we're going to see more of those kinds of studies. We're probably going to be looking at more precision-based treatments, just like the enzalutamide study, looking, which is showing that perhaps a subgroup of women with triple negative breast cancer who have an androgen receptor signature may be the patients we need to look at for enzalutamide. We are also seeing a continued emphasis of quality of life in terms of the approach to women with metastatic disease, whether that be in the bones or brain or elsewhere. But above all else, I think we can look at these results and show that hope is indeed continues to be on the horizon for women with metastatic breast cancer. And with that, I'll close. And thank you very much for asking me to join you today. Christine, I'll turn this over to you.
Thank you, Dr. Dizon. So a couple of questions have come in. And
yep.
Just a moment. Can the zoledronic acid outcome be extended to patients on Xgeva?
Yes, so that's a really important question, and the answer is no. Xgeva is quite a different drug from the bisphosphonates, but I will say that right now there is interest in sort of trying to explore whether or not the same principle of extended therapy does extend to what's called the rank ligand inhibitors, which is what Xgeva is, rather than a bisphosphonate. So because of the mechanism of action, in fact, how the drug was manufactured and the type of drug it is, I'm not sure. In fact, I would probably say I would not extrapolate these results for zoledronic acid to Xgeva at this time. Again, I think for folks on zoledronic acid, the issue has arisen because this does require trips to an infusion unit to get it as an intravenous infusion. And so if there's a way we can back off on folks going to the infusion unit less frequently, it may actually help them not only financially, but just in terms of coordination of care and just interrupting their life, really, because of the more frequent visits for infusional therapies. Xgeva is given as an injection, so that pressure to give it may not be as great, but still, it is quite an expensive therapy. And I do believe that there are still some studies looking at how the optimal timing of Xgeva therapies.
Thank you. So another question, is there any active research on non-BRCA germline mutations such as BRIP1?
Yes, that's an interesting question. So we are now recognizing that BRCA mutations are not the only genes that are associated with an increase in the risk of breast cancer. But that field is really quite premature. For example, although we know that there are mutations, PALB2 might even be some of the mutations in the repair pathways that are affected, like RAD1. We don't know yet how our interventions impact subsequent risk. So will a prophylactic mastectomy protect as much as it does in a BRCA mutation? Indeed, what ages should patients, if they are going to consider prophylactic mastectomy, do they need to do it younger older or at the same age. So I think what we're going to see probably in the next 5 years is a better understanding and a maturation of what these other genes do in terms of breast cancer risk. And until we sort of understand that, we can't necessarily understand yet how to interfere with breast cancers after those other mutations. So I think we are probably in our first, baby steps in terms of understanding other genes that are associated with breast cancer. And we're going to look to the mutations in BRCA to lead the way of how this whole field can develop. Recognize that PARP inhibitors, while available for mutations for women with cancers related to mutations in BRCA, there is none yet available for breast cancer associated with mutations in BRCA. In olaparib, which was the first to be approved for BRCA mutation carriers, has a very specific approval for women with ovarian cancer.
So another question is, should metastatic breast cancer patients have genomic testing? And if so, how many or what genes should be tested?
That's a complicated question. The answer I would say is, if there are therapies locally available, then I think genomic testing makes sense. The issues that come up with that is, right now, the commercially available genomic tests don't allow us to choose which genes we want to interrogate. So, for example, Foundation Medicine will give you a whole list of genes that are tested on any specific tumor. Now, there is a study that was just launched by the National Cancer Institute, which is called the MATCH trial, which is looking at patient tumor mutations and trying to get them into this very large umbrella study, which has multiple arms, multiple drugs, looking at multiple different mutations. At the Mass General, we will generally use genomic sequencing in our phase 1 group to help target patients to specific drugs based on tumor biology. As a general rule, that's the only place where I'm actually using genomic testing. And in the absence of a clinical trial, or in the absence of good standard therapies, I find next generation sequencing or genomic testing in metastatic disease of fairly limited value. So the bottom line is, if there is something we can do with the results, it does make sense to do. A lot of our trials, just like in the androgen receptor study, there is a genomic biomarker that's being attached or being proposed as something that can help identify patients to who will benefit for this trial. In those kinds of cases, the trial may be specific as to what biomarker will be tested. And even if you have a genomic sequence, you may still need to undergo a test specific to the trial. So again, I think it just depends on what we are planning to do with that information. That should be the general rule in terms of genomic sequencing of anyone's tumor.
Thank you. So just an additional follow-up question on that. How frequently should tumors be biopsied?
That's, again, a really great question. There's a sense in some other fields in oncology, like melanoma, that as tumors get treated, other mutations may become manifest. So serial biopsies are being used on clinical trials in melanoma to help sequence therapies in a rational way. It does make sense in melanoma because there's been this explosion of new therapies for the disease. In general, I do try to get biopsies on women when they first present with metastatic disease. I consider doing biopsies in cases of a mixed response. i.e. patients who have, say, liver metastases as well as bone metastases or a lung metastasis. If subsequent scans on a treatment show responses in some but not others, it might be worthwhile to biopsy the non-responding lesion and see how the DNA has changed. But again, it does tend to be determined by how many options do I have available, and do I need new biologic information to make that decision? So right now, serial biopsying is something that we're strongly considering doing on trials. The MATCH trial is actually incorporating serial biopsies so that if someone goes on arm A of this trial because they have mutation X, and then she progresses, a repeat biopsy is being done in that trial to see if she can go on another arm of the study.
Right. And I heard a little bit at ASCO about multiple site biopsies. So taking samples from the same tumor from different locations. Can you talk about that a little bit?
Well, it's along the same lines. So what we struggle with is, and it's probably clinically true, is that tumors are very heterogeneous. So just because you have a HER2 positive breast cancer probably doesn't mean that all of the cells in that cancer express HER2. So it's that heterogeneity that's driving this multi-site biopsies to try to better understand the heterogeneity of a tumor. Again, it's going to really, it may be opening Pandora's box in a sense though, because if a tumor expresses HER2 in, say, some cells or in one tumor and it doesn't in another tumor, are you really not going to give HER2 therapy? I would argue you would, because we're always trying to use that information to identify patients who should get trastuzumab rather than who should not. But the whole context there of multi-site biopsies is really to get a better understanding of tumors from a more global perspective and in terms of trying to identify the heterogeneity of those tumors.
Mm-hmm. And someone is asking, when no tumor is present, how do you test and monitor metastatic disease?
So if no tumors are present, how do you test them for?
How do you test and monitor metastatic disease?
Oh, if someone doesn't have tumor present or does not have symptoms present, then I think the bottom line is that there is no rush to start therapy. So in general, for patients with metastatic disease, I will begin treatment for either radiographic or radiological findings and or tumor-related symptoms. If someone does not have those things, then I will oftentimes observe them and just have them under very close surveillance. To me, close surveillance is monthly examinations and histories. It's not, I'll see you in 6 months. It is actually, I'll see you in 4 weeks. And usually those visits in a very frequent period are useful because you can get an idea or a sense alongside my patient of how the tempo of change is occurring. And then also together we can make a shared decision on how often and when imaging should be performed.
Thank you. And several people are asking about any kind of research being done in metastatic lobular breast cancer.
Right. So lobular breast cancers, we're actually, I don't know of any specific studies being done in lobular. What we're really, I think, what you've seen in ASCO is less of diseases focused in on histology. So no diseases in looking at ductal carcinomas versus lobular carcinomas. What we're seeing is the start of trials based on histological features, so hormone receptors, HER2 positivity, these are the things that really caught my eye. It's very rare to see studies, particularly in metastatic disease, by histology. I think in general there's a sense that metastatic disease, whether it started as lobular or as ductal, the behavior of these tumors are likely being driven by either mutations, by receptor expression, or by other biological means.
Thank you. So someone is wondering if metastatic breast cancer in males, if the treatment would be different than treatment that's recommended for women.
The biggest way that treatment is different for men with breast cancer is the choices of hormonal therapies. We generally will administer tamoxifen rather than the aromatase inhibitors in men, particularly as a first-line therapy. Part of that might be historical, but there's some very small data sets suggesting that maybe the AIs are not as effective. In terms of the treatment in metastatic male breast cancer, again, it's going to be driven mostly by the genomic or histologic signature of that tumor. So we would be treating a hormone receptor or triple negative breast cancer the same in a man as well as in a woman with metastatic disease. Same thing goes with triple negative disease. Some clarification may be necessary if it's hormone receptor positive, i.e. the use of tamoxifen versus an aromatase inhibitor.
There's a couple of questions here about drug resistance. So can you explain why AIs sometimes just stop working?
Right. You know, I think the field of drug resistance in metastatic breast cancer is actually one that's also in evolution. We don't really have a great sense of what the mechanisms, probably because there's multiple mechanisms, are of drug resistance to the aromatase inhibitors. It might be, you know, if you look at tamoxifen, we know that there may be changes in the estrogen receptor that make it resistant to tamoxifen. Where we probably still need to do a lot more work into the drug resistance of these agents that are being used to treat breast cancer. So there's no easy or simple answer to why one gets, quote, resistant to an AI.
Okay, thank you. So someone is saying that basket trials was kind of a buzzword that came out of ASCO. Can you talk a little bit about that?
Right. And the basket trials is essentially like the NCI's match trial, and essentially, you know, if anybody has ever participated in a clinical trial, the usual phase 2 trial is a single-arm study. Usually it takes about 30 to 40 patients, and it's run, it's one arm, and it's done, you know, serially. So you open one phase 2 study, then you can open a, when that's done, you open your another phase 2 study, and it takes a lot of time, and there's this recognition that progress can be very slow with these serially run phase 2 trials, particularly as we're now looking at more targeted therapies, trying to find people who fit a certain phenotype that might predict that a specific drug will respond might be quite difficult. So what the NCI and other institutions have done, I think some of our pharma companies have even done, is that they try to create a master protocol where multiple arms are embedded in the trial. Each arm can open and close based on results, but it's sort of a master protocol for patients to enter, and an arm is identified specific to the patient's genomic results. So in the MATCH trial, say you have a BRCA mutation and they have a novel PARP inhibitor, you would preferentially be placed into that arm of the trial rather than randomly assigned to another arm of that study. And then we would follow you to see how your results are. It is very also similar to the I-SPY 2 trials, which is looking at drugs and trying to match the patient to the drug. In terms of the I-SPY trial, what they're doing is called adaptive randomization. So, while the first few patients may be randomly assigned to any of the arms, there's a planned analysis to see if a pattern emerges in each of the arms, and if they can identify a pattern of responders, then the trial adapts so that patients who then subsequently meet the criteria that seems to predict response only will go into the arm of interest. But the whole notion of an umbrella or a basket trial is to try to pool resources to do these cross-oncology clinical trials to answer biologic questions in the fastest way possible.
So there are so many more questions. I know we only have 5 minutes. I wish that we could answer all the questions, but I think probably we have time for maybe just a couple more. So someone is wondering, if you are originally on a hormonal treatment, then go to chemotherapy, when and if that fails, can you then go back to hormonal treatment?
The answer is quite simply yes, and we sometimes will do that. So much goes into sort of the choice of treatment at any one particular point in time. It might be, you went from endocrine therapy to chemotherapy because liver mets developed and there was a sense that we need to get it under control, for example. In that case, chemotherapy may be the quickest way of achieving a response, but say then that treatment ended up being toxic to you 2 to 6 months later, in which case you might need a break, although that is not something that you'll necessarily want. We can retry endocrine therapy after that point. Really, there's no rules that govern the choices of treatment, and I think with the vast options that are seen for women with metastatic breast cancer, the way to be treated is a highly, highly individualized way. But for women with hormone receptor positive breast cancer, endocrine therapy is something I always and will continue to think about as an option for them.
Okay, great. So someone's asking about long-term effects for metastatic patients with bone metastasis only. Is there a higher incidence of stroke or heart disease associated with long-term use of hormonals?
It depends on the hormonal therapy. We know that tamoxifen, for example, will increase the risk of venous thrombosis or a cardiovascular disease. We haven't seen the same with the aromatase inhibitors thus far, but the aromatase inhibitors, again, can cause increases in the risk of a fracture. Tamoxifen can cause an increase in cardiovascular events, but some of the aromatase inhibitors have been associated with worsening lipid profiles. So again, I think the whole notion that endocrine therapy is benign is not true. There can be some health-related effects apart from cancer that can be induced. So that the decision about hormonal therapy, how even chemotherapy, has to be highly individualized.
Okay, several people are asking about fatigue, that they're really struggling with fatigue. Do you have any suggestions about how they can deal more effectively with it?
Yeah, I bet fatigue is often not a symptom that occurs in isolation. I oftentimes will try to look for secondary exacerbating factors. It might be distress, it might be anxiety, it might be depression, it might be insomnia. So I think a lot of the things we should try to do is try to look for other associated symptoms that might be contributing to fatigue, and getting those things addressed, whether it be with, anxiolytics or antidepressants, or even something as simple as looking at sleep hygiene. I think for most patients, if they are experiencing distress, my practice has been to refer early on to palliative care for symptom management, not for hospice. But because I do think, and my experience has been, patients who get plugged into palliative care early also have better quality of life. Pharmacologically, things that can help with fatigue are short courses of steroids like dexamethasone. I haven't had that much luck in terms of psychostimulants in terms of fatigue. But I would strongly favor mind-body or complementary therapies. Exercise can also be a very good therapy for fatigue, and it doesn't mean you have to run a marathon when you feel exhausted. It does mean walking consistently, maybe even 2 or 3 or half a mile, I should say. But remaining active is actually one of the things that can help with fatigue, and then looking for secondary causes is also really important.
Thank you. It was very comprehensive, and I hope some people can find some relief. So thank you so much. Dr. Don, it was a great, great program. You packed a lot of information into the short time that we had together, and you answered so many questions. I'm sorry we weren't able to get to all the questions. This will be available. A recording of this webinar will be available, and you will all receive a link to that recording. So I would just like to again thank Dr. Dizon for your time putting this presentation together and for being with us today, and to the Metastatic Breast Cancer Network for always being willing to partner with us.